Hi friends, welcome to my YouTube channel Dr.Sreenivas Medical Concepts. This is Dr. Sreenivas, neurologist from Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. Today we will discuss the functions and dysfunction of cerebellum. Cerebellum. What is the role of cerebellum? Cerebellum is tasked with bringing finesse to the motor system. Cerebellum is tasked with bringing finesse to the motor system. So as long as the cerebellum is intact, there is neither undershooting nor overshooting. So it brings finesse and the optimal movement. So how does this happen? How is cerebellum responsible for bringing finesse to the movement? It is very simple. If you understand the three cerebellar peduncles concept, it is very easy to understand how cerebellum brings finesse to the movement. We have three cerebellar peduncles: superior cerebellar peduncle, middle cerebellar peduncle, and inferior cerebellar peduncle. As the name suggests, superior cerebellar peduncle connects to the midbrain, middle cerebellar peduncle connects to the pons, and inferior cerebellar peduncle connects to the medulla oblongata. Fine. Now we have afferent pathway and efferent pathway. Afferent pathway is the pathway which is responsible for transmitting information from the other parts of the body to the cerebellum. And the efferent pathway is the pathway which transmits information from the cerebellum to the other parts. So we have superior cerebellar peduncle, middle cerebellar peduncle, and inferior cerebellar peduncle. So the intended movement, what the brain intends to do, comes from the frontal cortex to the pons, and through the pons to the cerebellum, to the middle cerebellar peduncle. So this is the intended movement, what the cortex has planned to do to the movement. So this is the intended movement. But then because of the cortex, the actual movement takes place. The actual movement takes place. So this is transmitted to the cerebellum through the inferior cerebellar peduncle, medulla oblongata, and cerebellum, the spinocerebellar tract. So the intended movement is transmitted from the frontal cortex through the pons and the cerebellum, fronto-ponto-cerebellar pathway. The actual movement is transmitted from the muscles, the spinocerebellar pathway, to the medulla oblongata and the cerebellum, the inferior cerebellar peduncle. So now what the cerebellum does is that it tries to coordinate, conduct, organize the intended movement from the actual movement which has taken place. So it tries to conduct and coordinate. Any discrepancy it tries to analyze. If there is overshooting, it undershoots. If there is undershooting, it overshoots, giving the finesse to the movement. So how does this give the finesse to the movement? From the cerebellum, now it is an efferent pathway. It goes from the superior cerebellar peduncle, midbrain, from the dentate nucleus, crosses over to the opposite red nucleus, goes to the opposite thalamus and the cortex, dento-rubro-thalamo-cortical pathway. And finally, all the movements have to take place through the cortex and the corticospinal tract. So it's a double crossing, dentato-rubro-thalamo-cortical tract, and from the cortex comes to the corticospinal tract to the opposite side. So if the cerebellum gets affected, the manifestations are on the same side because of this double crossing. So nature has beautifully given a task to the cerebellum of giving finesse to the movement. So the information afferent comes from the cortex, the intended movement, the actual movement comes from the muscles, goes to the middle cerebellar peduncle and the inferior cerebellar peduncle. It then fine tunes, and then the most appropriate movement is traversed from the superior cerebellar peduncle, midbrain, cortex, dentato-rubro-thalamo-cortical tract. So this is how it gives finesse to the movement. Here we should understand one concept. The basic movements are done by the corticospinal tract. The basal ganglia and cerebellum only fine tune the movement. But the basic movement is done by the corticospinal tract. For example, if I want to put the button in the buttonhole, bringing the hands to the buttonhole is done by the corticospinal tract. But the fine, delicate movement, the finest to the movement, putting the button in the buttonhole is done by the cerebellum and the basal ganglion. So this is how cerebellum gives fineness to the movement. So very important point. So we have the inferior cerebellar peduncle, middle cerebellar peduncle and superior cerebellar peduncle. Fine. Now what are the functions of the cerebellum? To understand the functions of the cerebellum, we need to understand three parts of the cerebellum. Very, very easy, a simplified version. We have the central part, the vermis. We have an inferior portion, the flocculonodular node, and we have two cerebellar hemispheres. So we have vermis, the flocculonodular node, and the two cerebellar hemispheres. The oldest part of the cerebellum, the archicerebellum, is the flocculonodular node, which is otherwise known as the vestibulocerebellum. This vestibulocerebellum is concerned with the eye movements and the spatial orientation. So the vestibulocerebellum is concerned with eye movements and the spatial orientation. So any disturbance in this flocculonodular node or the vestibulocerebellum, which is the oldest part of the cerebellum, will cause eye movement disorders, nystagmus and spatial disorientation. The classic example of the flocculonodular node involvement, the classic disease is medulloblastoma. Right. Then we have the central part, vermis, to some extent the adjoining area, the paravermis. So this vermis and paravermis is a recently developed part of the cerebellum. The paleocerebellum, as it is in the center, it controls the axial movement and the locomotion, the movement, the gait. So vermis is the recently developed part of the cerebellum, the paleocerebellum, which controls the axial movement, the central part of the movement and locomotion. The typical example which affects the paleocerebellum is alcoholic degeneration. Then we have the two cerebellar hemispheres, which is coming out like this. This is the very recent development. That's why it's known as neocerebellum. Very well developed in humans. So it is in the lateral part, the cerebellar hemispheres. So it controls the appendicular movements, the movements of the hand. So the cerebellar hemispheres, this is the new part of the cerebellum, which is otherwise known as neocerebellum, which controls the appendicular movement. So almost all the cerebellar signs are associated with this cerebellar hemispheres. The hand, nose, coordination, all the movements concerned with the hand. And the diseases which can affect the cerebellum, especially the cerebellar hemispheres, stroke and then tumor. When we talk about stroke, we need to understand the blood supply of the cerebellum. Blood supply of the cerebellum is basically because of three arteries. We all know that the posterior circulation is two vertebral arteries in the medulla oblongata, forming the basilar artery in the pons, dividing into posterior cerebral arteries in midbrain, winding around the temporal lobe and coming to the occipital lobe. So the first vessel coming and supplying the cerebellum is the pica, posterior inferior cerebellar artery, which comes from the vertebral artery, which supplies the inferior surface of the cerebellum. The second artery is the anterior inferior cerebellar artery, which comes from the basilar artery and supplies the cerebellum. The third is the superior cerebellar artery, which also comes from the basilar artery and supplies the cerebellum. So if these vessels are involved, we can get cerebellar strokes. And another important disease which can affect the cerebellar hemispheres are the tumors. Sometimes all the three parts of the cerebellum can get affected. The archicerebellum or the vestibulocerebellum, or the vermis, the paleocerebellum, or the cerebellar hemispheres, neocerebellum, what you call it as pancerebellar involvement. Here it could be usually because of the diseases which are inherited, like autosomal dominant disorders like Macaulay-Joseph disease, or autosomal recessive disorders, the most important being ataxia, telangiectasia and Friedreich's ataxia. and of course any paraneoplastic conditions. So these are the functions of the cerebellum. One, the cerebellar hemispheres or the neocerebellum, precise movements of the limbs, hemispheres, stroke and trauma. Then the vermis, the paleocerebellum, where it is concerned with the axial movement and locomotion, and then the flocculonodular node, the oldest part, vestibulocerebellum, it is concerned with the eye movements and the spatial orientation. So it usually produces nystagmus and eye movement disorders. Fine, these are the functions. So very simple. So as of now we have learned how cerebellum gives finesse to the movement and what are the functions of the cerebellum. So having understood the functions of cerebellum, now let's focus on the dysfunction of the cerebellum. Cerebellar disorders, how do they manifest? Basically, the dysfunction causes an impairment in the sequence of agonist, antagonist and agonist muscle sequence. So when there is a dysfunction of the normal triphasic agonist, antagonistic and agonistic sequence of activity is affected. So what happens? It generally produces a condition known as dysdiadochokinesia. So agonist, antagonist, agonist, this sequence is gone, so they cannot tap alternatively. So this causes dysdiadochokinesia. We all know that when agonists contract, antagonists have to relax. This is known as Sherrington's law of reciprocal innervation. But when both agonist and antagonist contract, you call that as dystonia, co-contraction. In cerebellar disorders, agonist contracts and then immediately when the antagonist have to contract, it can't. It cannot help change over from the agonist contraction immediately to the antagonist contraction when the movement has to be interrupted. So this is the basic problem of the cerebellar disorders. So the normal triphasic agonist, antagonist, agonist sequence is impaired. The motor sequence is impaired. So what does this do? This results in dysdiadochokinesia. Not only that, when you try to test by asking the person to do finger to nose coordination, again the finesse to the movement is gone. As I said earlier in my class, in the lecture, it gives finesse to the movement. The finesse to the movement is gone. So either there is undershooting or overshooting. Dysmetria, where the actual measurement is gone, or dyssynergia, the sequential movement is gone. It is disorganized. The organized movement is gone. And then they can have intention tremor. As there is tremor, but when they come close, the tremor gets increased. So all these findings are there because of the impairment in the sequence of agonist, antagonist, agonist sequence motor movement, and then it is not able to give finesse to the movement. And then they can develop hypotonia. Hypotonia is because of decreased firing from the deep cerebellar nucleus, especially the red nucleus, to the facilitation of the motor sequence, and because of that there is hypotonia. Classic example is pendular knee jerk. So when you try to elicit the knee jerk, it keeps moving, oscillating up and down. And then another important finding in cerebellar disorders is nystagmus. To understand this, I need to talk about the vestibular component also. I told this in the neuro-ophthalmology nuances lecture last time. The vestibule, the labyrinthine complex, controls the third nerve on the same side with the sixth nerve on the opposite side. So when the vestibule is stimulated, the eyes will move towards the opposite side. Fine. Cerebellum inhibits this vestibular movement, and therefore when the cerebellum is stimulated, eyes will move towards the same side, because cerebellum inhibits this vestibular stimulation of the eyes. So when the cerebellum gets affected, when the cerebellum is deranged, eyes cannot move towards the same side, so eyes will move towards the opposite side. So eyes will move towards the unaffected side, and therefore nystagmus will be towards the same side. So in cerebellar lesions, eyes will move to the unaffected side and nystagmus will be towards the same side. Here we need to understand two important nystagmus: Brunn's nystagmus and rebound phenomenon. In Brunn's nystagmus, especially when there is cerebellopontine angle tumor, When person looks to the same side of the lesion, there will be coarse tremor, but when they change the direction, it becomes a fine tremor, fine nystagmus. So when there is a cerebellopontine angle tumor, the nystagmus, the fast phase is coarse, and then when change the direction, it becomes rapid. So direction changing nystagmus. So this is usually seen in CP angle tumors, cerebellopontine angle tumors. The second nystagmus, which is characteristic of cerebellar disorders, is rebound nystagmus. Rebound nystagmus. So what happens in rebound nystagmus? There is fast component to the side of the lesion, but it is when you look towards the side of the gaze, but it is transient and suddenly it changes direction when the eyes come back to the primary position. So this is rebound nystagmus. So in cerebellar disorders, especially in the flocculonodular node or vestibulocerebellum gets affected, eyes will move towards the unaffected side and the nystagmus will be towards the same side. You have two important nystagmus, one Bruns nystagmus which we see in cerebellopontine angle tumors, and rebound nystagmus which is very characteristic of cerebellar disorders, fine, which is unique of cerebellar disorders, right. Now, having understood the function, dysfunction and finesse, let's see the cerebellar disorders. So how do we approach cerebellar disorders? Acute, subacute, chronic. Acute is hours to days, and then subacute is weeks to months, and chronic is months to years. So acute, subacute, chronic. Acute, usually the cerebellar manifestations are profound because there is no compensation, and usually they are treatable. Suppose it is a toxin which is causing cerebellar manifestation, you stop the toxin, they become alright. So acute cerebellar lesions produce profound cerebellar manifestations and they are treatable usually. Whereas subacute and especially the chronic, the cerebellar manifestations are not profound or not very much manifest because the compensation has taken place. So the cerebellar manifestations are less, and the treatment also generally it could be tumors or some degenerative process. So nothing much can be done for usually for the chronic cerebellar disorders. So this is how we approach ataxia: acute, subacute and chronic. Now let's see what are the conditions which gives acute, subacute and chronic. So in acute, usually the common toxin is alcohol. Alcohol causes acute cerebellar involvement. Usually it can cause B1 deficiency, thiamine deficiency, and therefore produce Wernicke's encephalopathy. The phenytoin which we give for epilepsy, anti-epileptic drug, can also cause cerebellar dysfunction and infections like viral encephalitis. So we have alcohol, we have B1 deficiency, Wernicke's, we have phenytoin, and we have viral encephalitis. We see subacute, which takes days to weeks. The usual causes causing subacute involvement are cerebellar abscess, multiple sclerosis, medulloblastoma, paraneoplasia and gluten sensitive enteropathy. So we have cerebellar abscess, multiple sclerosis, medulloblastoma, paraneoplastic disorders and gluten sensitive enteropathy. Then chronic, going on for months to years. What are the conditions? We have basically inherited conditions. One is the autosomal dominant condition. What I've been saying, it is the Macarow-Joseph disease, which is very common, especially in India. We have autosomal recessive. Amongst these, the common disorders are Friedreich's ataxia and ataxia telangiectasia. Then we can have mitochondrial cause of ataxia, usually maternally inherited. And then we can have congenital malformations like Dandy-Walker syndrome, Arnold-Chiari malformation. They go on for a long time. And we have endocrine disorders, which is one of the treatable causes of chronic cerebellar disorders, hypothyroidism. So these are the common causes of acute, subacute and chronic cerebellar disorders. So now just talking about the important points of pearls. Cerebellum is the organ which gives the task, which gives finesse to the movement. It gives finesse to the movement. All the basic movement is done by corticospinal tract, but the finesse to the movement is done by cerebellum and basal ganglia. So it gives finesse to the movement through the superior cerebellar peduncle, which is an efferent pathway, having got information from the afferent pathway, the pontocerebellum and the spinocerebellum. Second, the functions you can divide it into three parts: vestibulocerebellum, the flocculonodular, which is concerned with eye movements, the vermis, which is concerned with axial movements, and the cerebellar hemispheres, the neocerebellum, which is concerned with the appendicular movements. And finally, the dysfunction, basically the agonist sequence of activity is lost. They can have hypotonia and then they can have nystagmus. So this is an overview of cerebellum functions, finesse and dysfunction. I've enjoyed giving the lecture and I hope you have also enjoyed listening to the lecture. If you have liked the lecture, kindly subscribe my YouTube channel Dr. Sreenivas Medical Concepts and Facebook page Dr. Sreenivas Concepts. Bye.